The great saphenous vein is the longest vein in the human body. Right now, it might be the source of painful, swollen varicose disease, but down the line, that exact same vessel is the premier biological conduit for life-saving coronary and infrainguinal arterial bypass surgeries. This animated chart shows what happens when patients with peripheral arterial disease also have a history of varicose veins. In 82.6% of those cases, the saphenous vein is no longer available to use as a bypass graft. Crucially, more than a fifth of those missing veins were intentionally destroyed by previous varicose vein treatments. This data points to a distinct clinical profile where preserving the vein is the priority. Younger patients, those with early-stage disease classified as CEAP C2 or C3, and anyone with established cardiovascular risk factors have a long time horizon where they might eventually need that bypass conduit. Conversely, clinical guidelines recommend standard venous obliteration for older patients without significant cardiovascular risk, or those whose saphenous veins have dilated beyond 10 millimeters. Because standard thermal ablation works by permanently destroying the vessel from the inside out, the decision to save or destroy the vein must be made at the diagnostic stage. There is no turning back once the procedure begins. Treating a varicose vein requires a calculated bet on a patient's long-term cardiovascular survival. If the goal is preservation, the diagnostic workup becomes highly demanding. Standard duplex ultrasound simply measures if blood flows backward for more than 500 milliseconds. That is not enough data to map a preservation surgery. A preservation method like CHIVA treats the disease as a mechanical plumbing problem, a venous-venous shunt. This diagram contrasts normal upward venous flow with a pathological shunt, where broken valves allow deep venous blood to escape into the superficial system and flow backward in a closed, pressurized loop. To correct this without destroying the vessel, the surgeon maps three distinct nodes: the escape point at the top, the saphenous trunk acting as the conduit, and the re-entry point at the bottom, where blood returns to the deep system through a perforating vein. Identifying that exact re-entry point is notoriously difficult. Standard ultrasound criteria are highly unreliable here, offering only a 13.9% sensitivity for detecting actual net outward flow through those lower leg perforators. Once the precise architecture is mapped, the patient's anatomy is categorized by the Franceschi classification into type 1, 2, or 3 shunts. The surgeon has to draw a complete architectural blueprint of these complex plumbing short circuits before making a single cut. Obliteration techniques skip the blueprint entirely. Thermal ablation uses a laser or radiofrequency catheter to burn the vein, forcing it to collapse and seal shut. Newer alternatives take a non-thermal approach to achieve the exact same result. Cyanoacrylate treatments glue the vein walls together, while mechanochemical ablation physically scrapes the inner lining while injecting a sclerosing agent. The CHIVA method uses targeted disconnections to correct the hemodynamics while keeping the vein intact. For a straightforward type 1 shunt, the surgeon performs a drain strategy called CHIVA 1. As you can see in this schematic, by tying off only the top escape point, the backward pressure stops. The main saphenous vein stays alive and drains through the lower perforator. Relieving that transmural pressure causes the vein to naturally shrink from an average of 2.6 millimeters down to 1.6. But if the architecture requires severing both the top and the bottom connections, a non-drain strategy, the blood has nowhere to go. Fluid traps inside the saphenous lumen, frequently causing temporary thrombosis and the formation of new varicose veins. Total ablation offers a highly reliable demolition. CHIVA relies entirely on delicate fluid mechanics and the precision of the operator to succeed. The demolition approach carries specific risks. Thermal ablation can occasionally cause blood clots to extend into the deep venous system, a condition known as endovenous heat-induced thrombosis. The glue and mechanochemical techniques eliminate the heat, but introduce different issues, like allergic phlebitis from hypersensitivity to the cyanoacrylate, or glue-induced thrombosis. This risk matrix compares the data. CHIVA delivers a massive safety advantage, reducing saphenous nerve injury risk to just 0.07, alongside drops in bruising. But there is a trade-off. At 24 months, CHIVA's recurrence hits 46.7% compared to 13% for ablation and 7.1% for stripping. When patients require those complex, non-drained CHIVA procedures, the initial failure rate jumps even higher, frequently requiring a second, staged operation months later to manage the recurring reflux. The choice comes down to prioritizing today or tomorrow. You can secure a highly effective, immediate cure that destroys the vessel, or accept the risk of future interventions to ensure a crucial biological pipeline remains open if your heart ever needs it.